Okay, so just a little bit about the story of this patient. So it was a 4-year-old male. He developed a fever and had some other symptoms going on. Those lasted for 4 or 5 days. And then his parents in the middle of that took him to like an urgent care clinic where he tested negative for COVID and flu. Then he starts feeling a little bit better, goes to his brother's baseball game, and he eats some blackberries, that like wild blackberries, and then some red berries that no one really knows what they were. His parents catch him and he spits them out. And then there's this questionable exposure to like a hemlock plant, which can be poisonous. So then that happens. The next day he develops these fevers again. So his parents become kind of concerned. They went to an outside hospital with the chief complaint of the skin irritation. He had kind of these weird lesions showing up around his body. At that hospital, he tested positive for COVID, and he received Decadron and Benadryl, and he started to have pretty good improvement, especially just like, not necessarily as much of his rash, but just like his being and how he was acting. And they discharged him with prednisolone. And his parents didn't really feel like they took everything seriously at that hospital, so they decided to come to the UK PEDS. At the UK ED, they found some lesions in his nares and on his ears. He had some oropharynx erythema, cracked lips, this rash going on, especially in his armpits, erythematous bilateral eyes. He was complaining of photophobia and some mild periorbital edema. He also had an erythematous anus and genitalia, and then erythema and swelling of his palms and soles. So at that point, he was admitted to UK. And the differential diagnosis at this point was, is it just something weird going on with COVID? I mean, pretty much anything seems like can happen with COVID. And is this a acute reaction to that weird plant ingestion? Or is this Stevens-Johnson or TEN? Is it MISC, Kawasaki's? So that was kind of where they were at. So a little bit of why I kind of wanted to present on this is I think that like in medical school, we all learn about like Stevens-Johnson syndrome, and then like COVID's going on now, but in med school, they don't really talk ever about like how it necessarily affects the eyes. Maybe like they might say they might get red eyes, but that's kind of all. And this was something that Katie actually saw the consult on here at UK. So it's realistic that we would see it. So just a little review in general about Stevens-Johnson syndrome. So if it affects less than 10% of the body surface area, then it's Stevens-Johnson. But if it's greater than 30%, then it's toxic epidermal necrolysis. And then in between, they just call it SJS/TEN. So normally the typical course of this disease is they have like a prodrome with some fever or flu-like symptoms, and then they develop the mucocutaneous and then the skin lesions. And that's the big thing to differentiate from other pathologies that seem similar to this, is it has to be the mucocutaneous as well as the skin. Most likely it's going to be from drugs that have recently been started or Mycoplasma pneumoniae, but there are other rare things like vaccinations or contrast exposure. And then there is certain populations that are more likely to develop this, people with HIV, malignancy, and then certain people are just genetically more susceptible to it. So most of the time, whenever we think about TEN and SJS, I feel like this is exactly what like pops into your head from medical school, but more eye related. So I guess I can make this a little smaller. Okay, so subconjunctival hemorrhage, epithelial defects, conjunctival membranes, and then the key thing that most people have, 78% have the bilateral conjunctival redness and purulent discharge. Then 50% of people are going to develop the superficial punctate epithelial erosions. And then 11% are going to develop the ankyloblepharon, where it kind of attaches out here, and then symblepharon in 28%. Most of the data says that around 80% of people who develop SJS will have some sort of ocular findings. So it can be very differing, but I kind of just focused on like the big ones, but these are like kind of just a continuous list of all the different ways that it can affect the eyes. So a little bit of the research that I did, I found there's actually quite a few case studies. Most of them aren't like a bunch of patients that they found, but it's 1 or 2 patients in each case study. So I just selected this one that I thought was interesting. So this talked about two patients. One was 48 years old. She had body aches and fever for about 10 days. Then she developed TEN. She came to the hospital. Her PCR was negative for COVID, but her chest x-ray was very concerning for COVID, and the hospital said that that was her primary diagnosis. And they felt like the TEN was caused by that because there was no other explanation. Very similar story for another patient in this case study, a 60-year-old woman with fever and sore throat for 10 days. Then she developed TEN, and her PCR again was negative, but they did a chest x-ray and CT on this girl, and they were convinced that she had COVID as well. Another thing that's been found is not as common as after the actual COVID illness, but they did find that the vaccine has been associated sometimes with developing SJS. So this was a case report after someone received their second dose, just a middle-aged female, and about 5 days later she developed, hers was mostly the mucocutaneous, but she did still meet the clinical diagnosis for SJS. So a little bit of the treatment. First of all, if it's COVID, you can't really stop the offending agent all too well, but if there is a drug or something, we always want to, of course, stop that. And then saline rinses, lubricant eye drops, or ointments. And then you want to start corticosteroids or antibiotics. Doing membrane sweeps to separate the adhesions, and then amniotic membrane transplant if it's severe enough. There's actually not that much evidence about systemic adjunctive therapies to help with the treatment of SJS. So a little bit more specifics. So if there's less than 1/3 lid margin involvement and the conjunctival defects are less than 1 centimeter, then you're just going to do moxifloxacin, cyclosporin, and then topical steroids. But if it gets more severe and you're involving greater than 1/3 of the lid margin, the conjunctival defects are greater than 1 centimeter, or if any corneal defects are categorized as severe, then you're going to want to start all those meds, but then also you want to get an amniotic membrane graft as soon as possible. Most of the data said that it needed to be done within 7 to 10 days to have any benefit. So circling back around to the case, so this boy, he had fever and prodromal symptoms. 7 days later, he develops these skin findings. He tested positive for COVID. There were no new medications that had been started. And he did later, like we talked about, he came to the hospital, was diagnosed with COVID and SJS. His was a clinical diagnosis. They didn't do any skin biopsies or anything, but they did say that they believe that that is what's going on. He was discharged on prednisolone, and he was discharged on the 10th of July. And last I saw on his chart, he was contacted 2 days ago. They contacted his parents, and they said he was really improving. He was pretty much back to his normal self, running around, having fun, and he had one new lesion, but everything else had really resolved. So he's doing really well. And that's all.
Questions or comments from the Zoom?
All right, just one quick comment, or I guess a question for the residents. So in more severe cases, we don't have a burn center, but in more severe cases that require more aggressive treatment, is there another condition that you'd be worried about or get consulted on? I guess this goes for any kind of burn patient. Okay, we don't get this again because we have a burn center, but this is if you were at that kind of trauma center, vexing consults. So you get consulted for overall compartments. The massive fluid overload that these patients receive. So they're getting multiple liters of oral saline an hour, and they balloon up. I mean, they're third spacing so much, and so they actually can get compartment syndromes, pressures in the 60s and 70s. And you can't die in
Wow.
I had a quick question for the faculty, I guess. Do you peel the membranes or not? Because it seems like the literature is kind of split.
I'm pointing at here.
Dr. Katz is online. Come easily enough. Yeah.
Yeah, I mean, I'll sweep, and it depends how traumatic it is, but generally, I'll try to get the membranes out of there. But I don't know that I have a lot of hard evidence that which way it makes a difference or not. I don't know if Seema's still on, what she thinks.
I think it's more comfortable and just sweeps away the inflammation if you can sweep the membranes away. just like with EKC. It's just proteinaceous deposit and can be so uncomfortable. So yes, just like Doug said, if you can, sweeping, I think, helps.
Another question, Pars and I were actually just talking about this. So Clay and I saw this on call and really just did pretty aggressive lubrication. He didn't, I mean, again, he didn't look too bad at all. And didn't start topical steroids in that case, but Pars was saying that Dr. Katz had mentioned starting it's good to start it kind of regardless if you see significant eye involvement yet. Is that right?
Yeah, I mean, you have to, if there's eye involvement at Stevens-Johnson's, I think you need to start some degree of steroids and
Okay.
typically antibiotic.
Yeah, he was, I think he was already on systemic steroids, so that was probably helpful there too, and had a mild case. I mean, I read the ER notes when I saw him back in clinic, and he just some conjunctival erythema was all I saw, no membrane formation.
Yeah.
And it was his eyes were completely white and quiet just 5 days later. But his dad showed me the impressive skin lesions, and also he was when I saw him, he was sort of at the sloughing stage, like he was just peeling everywhere.
Oh.
And he just scratch. I mean,
And I think
still had some new blisters. Go ahead, Doug.
I think it's important too to not a lot of these people to put some like Tobradex or some sort of steroid antibiotic ointment on their lid margins. A lot of these people, they recover, but they end up obliterating all their meibomian glands get obliterated. So it's nice to put some antibiotic steroid combo on the lid margins.
Good. Yeah. So good. Put that on our memory banks. Always start some topical steroid.
And they had called us because the primary team wanted to roll out HSV. That was kind of their bigger thing, which was kind of interesting for, I mean, I get it because this could be a first time presentation in a little kiddo. So that was kind of interesting before they started steroids. Yeah.
Yeah.
So.
It's good.
They're also very fixated on the hemlock.
Yeah, there is.
I was like, if he would have eaten a hemlock berry, he would be dead. But they-
I don't know the dosage, but
yeah,
heard it.
I have no doubt.
Okay, I'm telling the folks on it. So Clay says 6 leaves will kill an adult male, just so you know. So don't eat hemlock.
And the berries are more.
Okay, and berries are work. Okay, we're going to move on just because we have 3 more excellent presentations. Thank you, Leah. Great job.
Excellent.
Okay. We have here, hopefully to help us get the next presentation set up, Nick Fronted figure will be next.
I know some sort of.
And Nick, I apologize. Actually, I don't know the title of your talk, so I'll. Got that one up here.
I'll do it. High reward. Flash drive.
Oh.
But it's, I think,
No.
That's fair.
So I'll let him go ahead and give his presentation here.
The clicker or the keyboard?
Oh, you got all.
I don't think sorry. I don't think the pointer works. Okay. Use the mouse.
Okay. Hi, I'm Jack Loriano, for those of you that haven't met me. And today I'll be talking about postoperative endophthalmitis following glaucoma surgery.
sorry.
Sorry. Just click through the. Or maybe just the mouse. I'm trying. All right, so objectives, I'll discuss a recent case of postoperative endophthalmitis that we saw at UK. And then I'll discuss some of the literature comparing postoperative endophthalmitis between glaucoma drainage implant surgery and trabeculectomy. And additionally, I'll discuss some other causes of postoperative endophthalmitis. So last week on consults, Garrett and I saw a 91-year-old female who presented to RED complaining of left eye pain and loss of vision. She reported the day before her left eye became very irritated and painful, and that by the following morning, she was unable to see out of that eye with progressively worsening pain. She went to an outside clinic and was subsequently sent to RED. Some ocular history, she had a history of advanced primary open angle glaucoma in both eyes, status post tube shunt surgery for both eyes back in 2016. which were both complicated by chronic tube shunt exposure or erosion. The left eye developing in 2020 and the right eye developing in 2021. She did end up undergoing tube shunt removal in that right eye earlier this year, but had since been declining further surgery for the left eye as recently as her last visit in June. Review of systems was otherwise negative. On exam, she didn't appear in any distress. She was actually a very sassy 91-year-old lady. She was oriented ×3. Right eye was seeing 20/60. Left eye was only seeing hand motion at 1 foot. Tonometry we deferred. I'll discuss a little bit later, but the tube was pretty freely moving within the anterior chamber, so we didn't want to be messing around with the eye too much and have that jostling around. Her pupils, we did notice, were slightly irregular shaped, but we didn't think that was quite relevant to the case. And extraocular motions were full. Going on to slit lamp exam, right eye was pretty much unremarkable. Her left eye, she had some upper lid erythema, some conjunctival and scleral injection, and you could see supratemporally the tube and the plate kind of freely moving beneath the eyelid. Cornea had some fine KP, and then she had 4+ cell and 0.75 millimeter hypopyon within the anterior chamber. And here you could also see the tube freely moving. Initially on exam, it was kind of posteriorly through the pupil. And by the time we had finished the exam and had kind of manipulated the eyelid and had her move her eye around, it had actually migrated forward a little bit. And it was the point where it was touching the iris. And she also had some vitreous debris visible within the anterior vitreous. So here are some pictures of this patient. Here you can see her plate and tube that's exposed superior temporally. And then this is a good picture, I think, of the hypopyon. And then we also got a B scan, which hopefully plays. It's not the greatest quality because, again, we didn't want to press too firmly. I wasn't going to add that part. But hopefully you can see a little bit here of kind of some debris and inflammation. So she ended up, we said she had postoperative endophthalmitis, felt like a pretty straightforward case. She went to the OR for that night for tube shunt removal, vitrectomy, and tap and inject. Her vitreous sample and culture ended up growing serratia species. And then follow-up next day, her vision was stable, still hand motion. Her pressure was around 40. The hypopyon had resolved and she still had that anterior chamber inflammation. By post-op day 3, she saw Dr. Weinstein. Vision remained stable. Her pressure was decreasing and the anterior inflammation had almost completely resolved. And then I believe she saw Dr. Moore yesterday. Hadn't had a chance to ask him how that went, but hopefully well.
Completely quiet eye, vitreous and AC both. Really good view to the back of the eye. Had a vision of light perception. And pressure was 16.
Okay.
Looked great, couldn't see.
Light perception plus.
Sounds like things are going up for her. Okay, so now that was a relatively straightforward case. Now I'm going to discuss some of the findings in the literature that with my quick search that I found comparing postoperative endophthalmitis in trabeculectomy versus glaucoma drainage implant surgery. So incidence-wise, both pretty low. The estimated average for trabeculectomy is 0 to 5%, and with GDIs 0 to 6-ish%. Here are a couple specific studies that directly compared the two. The tube versus trabeculectomy study had an incidence of 2% for trabeculectomy and 1% for GDI. And then a later study, PTVT, primary tube versus trabeculectomy, had no cases of endophthalmitis. And then this is a study from Saudi Arabia that had very low rates as well. So some risk factors for endophthalmitis following trabeculectomy. The biggest one is development of phlebitis or blood-related infection, as pictured here. And these are just some kind of historical risk factors for phlebitis, including inferior bleb location, associated with like a 4 to 5 times increase in risk of bleb infection compared to a superior bleb. The thought is like increased exposure when it's an inferior bleb location to bacteria from the tear film, just kind of pooling in the tear leg. And then a limbus versus a fornix conjunctival-based flap. Historically, limbus flap has had worse rates of phlebitis as well. And then antifibrotics like mitomycin C and 5-FU. There's been some studies that showed like higher doses or higher exposure time can increase risk of like bleb leakage from or epithelial thinning of the bleb. And then when you have bleb leakage, that obviously opens up a source to bacteria directly into the bleb and into the rest of the eye. So then for tube shunt or GDI surgery, the biggest risk for endophthalmitis, like in our patient, is development of tube shunt exposure or erosion. Again, inferior placement of the tube shunt and plate has been associated with conjunctival dehiscence and subsequently increased risk of infection. And then this patch graft material, I saw more so discussed in a couple papers, whether that be a corneal patch, a pericardial patch, or a scleral patch. But it kind of seemed undetermined yet if there's any significant difference in rates of infection or rates of shunt exposure between the three of those. Then time to presentation, both will present on the more chronic side, kind of years later. Trabeculectomy, you can get a more acute, like weeks later presentation of endophthalmitis, but on average in the literature is around 1.6 years. And then for GDI or tube shunts, just because of the mechanism of developing tube exposure before developing endophthalmitis, that usually takes a little bit longer. And so the average in the literature I found was greater than 2.5 years from surgery to presentation with endophthalmitis. And then as far as the bugs that are causing these, for trabeculectomy, if it's more of an early presentation, staph species are most commonly found. As later on, it'll be streptococcus species. And then for GDI, streptococcus species were most commonly found. But for both, there can be a wide variety of gram-positive organisms like Serratia found in our patient, and then like Pseudomonas as well. So lastly, I just wanted to briefly talk about other surgeries that can commonly lead to postoperative endophthalmitis. And the big two are cataract surgery and vitrectomy. Both have, similar to glaucoma surgery, very low incidences. Risk factors for cataract surgery include like posterior capsular rupture, poor corneal wound construction or healing, and then age and diabetes. And then for vitrectomy, similarly inadequate wound closure within the sclera, and then fluid versus gas fill. I saw like a gas or anything that can tamponade or help tamponade will help better seal the scleral wound, which can help prevent infection. And then for both, diabetes can be a risk factor as well. And these, conversely to glaucoma surgery, will present much more acutely within days after the surgery. And as a result, coagulase negative staph is the most common bug found. But again, there can be a variety and typically gram-positive bacteria. So in summary, incidence of postoperative endophthalmitis is low across the board. Phlebitis and tube exposure are the greatest risks for endophthalmitis post-TRAB and GDI respectively. They both typically present chronically on the year's end of things, whereas endophthalmitis after cataract extraction or vitrectomy is more likely to present acutely within days. And for all of them in culture positive endophthalmitis, if it's acutely, staphylococcal species are most likely, and if it's chronically, more likely to see streptococcal species. Those are my references. And then just thanks to Dr. Moore and Garrett for helping me with this presentation.
I've got a question. Can you hear me? Can you hear me?
Yeah.
Is that- So as far as those incidences of endophthalmitis, this may have changed. I always remember being taught that those incidents in glaucoma are percentage per year. For a lifelong risk, every year you still have that same risk, whereas cataract surgery, it's a one-time risk. Are those statistics that were being quoted a lifetime risk or a per year risk for the glaucoma?
I unfortunately am not sure about that. Unsure if the glaucoma faculty can help me out there.
I need to go back and look at the literature, but our best data comes from the 2 versus Travis trial, and that is longitudinal now for I think up to 10 years. So they can provide the cumulative incidence that far out. But to Dr. Katz's point, absolutely, that those devices are in your eye forever, and that erosion risk is there forever. It would only increase on like cataract surgery, which is
I was always taught him, this is 25 years ago, we used to say for the Travs, I remember we used to quote people that there's a 1% per year risk, at 1% every year risk sort of thing. It's probably lower than that, but that's what we used to say.
Trying to make you all feel better.
Yeah.
Those numbers aren't as high as they look.
I know we're running out of time. That was a great presentation, 2 great presentations, but just a quick comment because this one is weighed at me heavily. She's a really sweet woman. She's 91, and as Karen Jack was saying, she's just real spunky. And she presented on Tuesday at Huffman at 8 a.m. She got her surgery with us after midnight that night. And she told me yesterday that her caretaker, the person who got sick right now because it was so stressful on them, and she is just as good as can be. So the point that is trying to make is that her initial surgery was back in 2016. She had just really tough, terrible conjunctiva, but she was on maximum medical therapy with pressure in the 40s at the time. And so I'm just like, should I have ever done that surgery? Had we not operated, I think she would have lost her vision completely, and she got at least 6 extra years of vision. So I don't know what the right answer is, but at least she was able to see then, and now she's had this awful outcome afterwards. So it's definitely a mixed bag.
In the old days, Thomas Smith used to be behind Florence Pentecost. I was 9 lives and I get it, and any others, I would just leave out. I think that any studies that have ever looked at that, I can't use that instance further.
Does, it's appropriate.
You think it increased the risk of drug-resistant organisms, but at the same time, and Dr. Katz can talk, K-Pros, they have them on chronic oxyfloxacin, so they're always on an antimicrobial.
Their lifetime risk was less because they died of aplastic anemia from their.
Well, in every country but the US, they use chloramphenicol still, because the aplastic anemia thing is way overblown and not present at all with drops, and from my understanding, chloramphenicol is really low or likelihood of getting resistance built up to it, but we can't use it in the US.
It's chloramphenicol is used in Europe, like it's been.
Yeah, they still.
We somehow put the FDA or somebody put the links on it here, but it's
Already
well accepted in
It was a
parts of the world. Okay, we're gonna go on just because of time. This is Nick Bontrager, and he's going to be giving our 3rd presentation. Thank you, Nick.
All right, so today I'm going to talk about a case of an ocular mass that we saw in clinic a couple weeks ago. So a 32-year-old female comes to clinic with a chief complaint of 1 year of progressively worsening vision, increasingly blurry. She was told that she had a mass in her left eye during a routine eye exam at the Walmart Vision Center and was referred to Bluegrass Retina Associates, where she was given a preliminary diagnosis that we'll come back to in just a little bit. From there, she was referred to U of L Ophthalmology for evaluation, and then she came to University of Kentucky Clinic a month after that for a second opinion. For her presentation to the clinic, her medical history, she had a history of thyroid papillary carcinoma with metastasis in 2011, status post-thyroidectomy and iodine ablation. She had several moles that had recently increased in size and weekly migraines. For her ocular history, like I said, with her chief complaint, she's had progressively worsening vision for the past year, and then has also noticed some white flashes in her left eye multiple times per day. I forgot to specify her progressively worsening vision is specifically in her left eye. And then she's had no floaters or pain in either eye. Her visual acuity in her right was 20/20, and in her left was count fingers at 4 feet. IOP was 18 on the right and 21 on the left. And then slit lamp exam on the left showed shallow anterior chamber and a large mass posterior to the iris conforming to the lens. So here's some slit lamp photographs. Not the most high quality images, but you can see what appears to be a mass behind the iris here. So definitely something concerning. After seeing this, we wanted to do a B scan of this patient to try and further characterize that mass that we were seeing. So here's some results from that B scan. So as you can see, there's a pretty decently sized mass behind the iris. Pretty homogeneous, low internal reflectivity, appears to be hyperechoic with maybe some posterior shadowing in some of these images. Then here's the A scan result for comparison. As you can see here, there's between where the retina would be and the iris, you can see a peak that might be corresponding to a mass that also seems to have some low internal reflectivity. With this scan information, the differential diagnosis for a mass near the iris would be, I guess the top would be a uveal melanoma of some type, including ciliary body and iris because of the mass's location. We would also be thinking about maybe some sort of metastasis to the iris. She does have a history of thyroid cancer. She has noticed some new skin lesions with some new changes. It could also be something like an iridic cyst or an adenoma of the iris pigment epithelium. So as far as for diagnosis, we were thinking that the B scan features were consistent with the suspected ciliary body melanoma that she had been diagnosed with at Louisville and at the outside retina clinic. So I think the specific description from the B scan was a large mass at 8 o'clock, largest diameter 17 millimeters at the base and just over 12 millimeters in thickness, low internal reflectivity and an associal retinal detachment. And then it was conforming to the posterior lens surface. So really what was making us think ciliary body melanoma versus some of those other things on the differential was the size combined with the location. It'd be unlikely for some of those other things to be this large. So the management for this case, this patient was referred to oncology for staging scans. The uveal melanomas have a very high risk of metastasis, so that was something we were worried about. She received a CT chest, CT abdomen, pelvis, and currently pending MRI orbits. And then the current plan for her is enucleation of her left eye with orbital implant insertion. I think she just talked to Dr. Timoney in the last few days, or just was seen in his clinic for evaluation for that. And then so far on her imaging, there has been no evidence of metastatic disease on the CT chest, abdomen, abdomen or pelvis, sorry. And then her MRI of her orbits is still pending. She's going to continue to follow with hem-onc every 3 months with repeat body imaging to evaluate for metastases because there is such a high risk of those. So some general things about uveal melanomas. A uveal melanoma is a malignant tumor of the melanocytes in the uvea in either the iris, ciliary body, or choroid. It is the most common primary intraocular tumor in adults, and it's most commonly derived from the choroid, followed by the iris, and then the ciliary body. So this is the rarest type of uveal melanoma that this patient had. Here's some pictures to give you an idea of what these might look like. And then, I guess ciliary body melanoma compared to the other types of uveal melanoma, it's usually found larger than the other uveal melanomas, probably because it's sort of hidden by the iris and presentation can be delayed because of that. In a study of about 8,000 eyes with melanomas, ciliary body melanoma was found at an average of 6.6 millimeters versus 2.7 for iris melanoma and 5.5 for choroidal. And then tumors of the same size carried slightly more long-term risk for systemic metastases when located in the ciliary body versus the choroid or iris. So ciliary body has a combination of more likely to be found large and then more likely to have metastases for the same size. So overall, it's probably worse to have than the other types. So the treatment options for a uveal melanoma in general, the primary goal is to prevent metastases in the long run. Local resection can be performed for very small lesions. Plaque brachytherapy, which is basically a radioactive plaque on the surface of the eye, can be used for intermediate sized lesions. And then enucleation is the classic treatment for preventing metastases and can be used for lesions of all sizes, including large ones such as this. And then plaque brachytherapy has been shown to have comparable results compared with enucleation for preventing metastases. But we decided to do enucleation for this patient because of the size of the patient's tumor. Plaque brachytherapy has been shown to have comparable efficacy for reducing metastases, but it's also been shown to have some complications, including radiation retinopathy, radiation-induced cataract, and some of these other things listed on this slide here. Those complications are generally dose dependent, and the plaque size required for this size of a tumor, 17 millimeters by 12 millimeters, would almost certainly cause complications in the long run for this patient. So the general prognosis for uveal melanomas. So I put a red box around the greater than 10 millimeter size because that is what this patient had. So for any general uveal melanoma, the probability for systemic metastasis is shown by these columns over here. For 3 years, it would be 28%, 5 years, 40%, 10 years, 51%. So very high likelihood, which is why she needs consistent and short interval follow-up with hem-onc for regular body scans. So overall review for this case, uveal melanomas can arise from the choroid, ciliary body, or iris. They may be asymptomatic at first, progressing to blurring and loss of vision. Ciliary body melanoma is the least common main variant of the uveal melanomas. And then treatment may consist of local resection, plaque brachytherapy, or enucleation, depending on the size of the tumor. And then prognosis and long-term survival are generally poor for uveal melanomas, and chance of metastases is directly related to tumor size. So, and here's my citations, and thanks a lot to Paris and Dr. Pearson for your help with this presentation.
Something I was racking my head about when we saw this patient was how photophobic she was. And I'm wondering if maybe it was the fact that it was in the ciliary body that was making her so photophobic. I don't know, maybe she's just young and had a healthy retina in the other eye. I don't know. And then I think we need to know more, but I think we're trying to figure out if immunotherapy would be helpful for these. I think the Shields group is trying to figure that out now. Given her age, I do wonder if that would be like a worthwhile endeavor. I mean, that's up to hem-onc, but
Are there other national trials on immunotherapy specifically for for uveal melanomas?
We centered to hem-onc, and basically the first response was, I have nothing to offer. It's truly local management.
Yeah. Yeah, that's a good question. I don't know whether, I wonder, MD Anderson, you know, it's kind of a.
Yeah.
I wonder.
I mean, right, because like melanoma silently can metastasize. Like that's why we track them. Like you're saying like, oh, we're gonna take this out. But like the fact is people do have mets afterwards.
She has no evidence, she has no evidence of systemic.
As of right now, I mean, the MR, the head is pending, I think, so we don't know for
Yeah.
sure.
Interesting.
No, it's quiet. It was just a hazy view, but there's no cell.
I was just curious if it was like just chafing on the iris just because that the
Yeah, maybe that, yeah.
Yeah, that's a good point.
blood for dilated eye exam.
Yeah. All right, so just so we don't shortchange our last presenter, great job on that case, Nick. Harsh Patel is going to talk about another very interesting condition.
Hey everyone, my name is Harris Patel. I'm a fourth year medical student and had the opportunity to work with a lot of you over the last 4 weeks. So I appreciate your grace and patience that I learned with you all. I had the opportunity to go to the Walsh presentations for nanos this year. And what I learned was the more outrageous the name, the case presentation name, the more intrigued I was. And so hopefully this captures your attention for a little bit. And by the end, hopefully it all makes sense. So I have no disclosures. So we had a 14-year-old boy present to the neuro-optho clinic with painless bilateral vision loss. He had been noticing decreased vision since 2019 and seen 3 different providers, 1 optometrist and 2 ophthalmologists in Louisville. His vision was as bad as 2300 in his right eye, and it was counting fingers in his left eye at 5 feet. At those visits, they had unremarkable ERG, MRI, and genetic testing. His previous visit with the retina specialist showed bilateral optic nerve atrophy, and so he was referred over to the neuro-optho clinic. Of note, he had spontaneous improvement in his vision since June of 2020. In terms of past medical history, yep.
We can't see your presentation on Zoom.
Okay, I'm sorry. Let me see if I can.
Thank you for letting us know.
Sorry about that, Dr. Kapoor. How about now?
Yeah, we can see it now.
Thank you.
Okay, great. So in terms of past medical history, he had normal achievement milestones. Family history is unremarkable for eye diseases or any neurological diseases. He was up to date with all his vaccinations, and birth history is unremarkable as well. He didn't have any diplopia, any other conditions, any other neurological symptoms or any systemic symptoms such as fever, weight loss, or malaise. In terms of physical exam, his visual acuity had improved to 20/50 in his right eye and 20/40 in his left eye. He had decreased color vision and contrast sensitivity bilaterally. He had no pupillary defects or any ocular misalignments. His fundus exam showed bilateral optic atrophy with optic nerve pallor superior and temporal to the disc, and his vessels were just fine without any telangiectasia or any tortuosity. In terms of OCT, it showed some thinning of the RNFL, superior, inferior, and temporal to the rim. His visual field showed some cecocentral scotomas bilaterally. There's a little bit low reliability on these tests here, but him being a 14-year-old kiddo is probably the best we were going to be able to get. In terms of imaging and diagnostic workup, his MRI of the brain in orbit showed normal structures without any hyperintensities. His testing came negative for NMO, MOG, any vitamin deficiencies, any heavy metals, and his ACE was also normal, so no concern with sarcoidosis. His testing did come back positive for ANA, however, that's unspecific for anything. His lumbar puncture had elevated opening pressure at 31.5 centimeters of water. He had normal CSF studies and a normal MS panel, so no bands. His notes from his other providers showed negative testing for any common genetic mutations. So he was started on Diamox daily and continued to have visual improvement. His OD was 20/25 and the left eye was 20/40. And then we also consulted Dr. Maldonado and the neuroimmunology clinic as well for their recommendations. However, about 4 months after we saw him in clinic, he developed some intractable nausea, vomiting, and was admitted to Norton's Hospital in Louisville, and they did a repeat MRI. At that repeat MRI, it showed some characteristics for NMO. He had some new brainstem lesions of the dorsal medulla and pons and concern for involvement of the area posterior. And so those neurologists there, this being very characteristic for NMO, especially with the bilateral vision loss and then spontaneous improvement, were concerned he was having NMO symptoms and diagnosed him with antibody negative NMO. They did some NMO and MOG panel testing at the at Norton as well, and it came back negative 2 times. So they were pretty confident that this was antibody negative NMO. Neurology was ready to start treatment with rituximab. However, the mother wanted a second opinion and came back to Dr. Maldonado's clinic. There we found that with comprehensive genetic testing that the mother and the son were homoplastic for a rare mitochondrial DNA mutation listed here at 4171. Looking through the literature, there was only one case of this exact mutation, and it presented similar to what our kiddo had. He had bilateral optic neuropathy and bilateral brainstem lesions, just like what our kiddo has. So a little bit more about Leber's hereditary optic neuropathy. It's the most commonly inherited mitochondrial disorder, and mitochondrial DNA is only inherited by the mother. And so the mother being homoplastic, all the children are expected to also have this mutation. However, it's only common to be noticed or have symptoms develop in 50% of males that have this mutation and 15% of females that have this mutation. It's common to affect males between the ages of 10 and 30. There's 3 pathological variants that account for about 95% of these cases, and those are listed on this slide. It's likely that the outside providers had tested these common mutations and missed the other mutations that Dr. Maldonado looked for. In terms of how this leads to vision loss, it's thought that the RGCs are selectively vulnerable to the mitochondrial dysfunction that this mutation has. In terms of treatment for LHON, the prognosis is generally poor if you have those pathologic variants that I mentioned on the previous slide, and leads to permanent vision loss and progression to legal blindness. However, the treatment encapsulates a multimodal approach. So you should refer to a cardiologist to evaluate for any conduction dysfunction. You should also counsel these patients on the importance of smoking cessation and avoiding any triggers that could lead to mitochondrial effects. Raxone is a medication that's approved in Europe and shows some visual benefit if started within the first year of disease onset. However, there is nothing in the United States. And they're also looking through the literature, there is some evidence that increased intraocular pressure could increase your chances of developing LHON if you're at an increased risk or have this mutation. Obviously, as I mentioned earlier, genetic testing is imperative. However, counseling is very complicated because of the incomplete penetrance. So some learning points for LHON or LHON plus, as you might see in clinic, maybe one day throughout your careers. It's a challenging diagnosis to make, especially if family history is pretty benign. MRI lesions are not typical. However, they can be present with LHON plus diseases and can imitate demyelinating diseases as we had with NMO. When to consider LHON, it's common in males with painless bilateral vision loss, usually at a young age. Suspicion should be high, the visual acuity is severely reduced, and if there's perimetry showing central scotoma or secocentral scotomas. Other indicative findings are disc hyperemia, telangiectasia of the retina, vascular tortuosity, optic disc atrophy, and nerve dysfunction, or any abnormal ERGs. In terms of prognosis for our patient here, about 19 months after initial MRI, we did another MRI, and it showed resolution of the hyperintensities of the dorsal medulla and pons. However, there are new punctate foci of the pontomedullary junction indicated by the red arrows. He was seen in clinic last month on the 22nd. Vision is stable. He's refracted to 20/20 bilaterally. No changes on macular OCT. There's no new neurological symptoms. Siblings are still getting genetic testing. However, they haven't developed any symptoms in the interim. And then he's been referred over to the Room Clinic for the positive ANA, and we're still waiting to hear if there's any other autoimmune disease present. And then he's on coenzyme Q right now. That is my presentation. Are there any questions?
Just a question about the fact that the vision got better with the Lebers. It's a little unusual for me to hear. I don't know if anyone's.
Well, it's a nadir. It hits the nadir first and then it comes back up,
Yeah.
right? I don't know why it got so much better for him.
I thought the same thing when I was
Well-
first started was kind enough to send me these presentations.
So
It's
Dr.
interesting in children.
Yeah,
Go ahead.
that's what we were talking about in Neuro-Ophthalmology Journal Club one day, was that Dr. Sudhakar had mentioned that children that have Lebers earlier on, because it typically affects adolescents, but like teens and like 20s, right? People that are younger do a lot better.
Yeah, and it's sort of this one-time event, so there's pretty good hope that he may maintain this good vision. Yeah, you're right. It's really striking. And I don't know whether that's related to the variant. Do you know her?
Yeah, I was gonna say, looking through the literature, if you have those pathological variants that I mentioned that account for 95% of these cases, usually those patients will progress and get worse and lead to permanent vision loss. However, this specific variant, especially in this also case report, that patient actually recovered vision. So it might be specific to this specific mutation that they have resolution of symptoms.
Are you guys writing that up? That's.
Yeah, I've sent it to Dr. Maldonado. We'll see when he gets back, but our plan is to send it to ophthalmic genetics.
Oh, when he gets helps with mitochondrial stability.
Yeah, it's so mitochondria electron transport chain, and that's one of the factors that help with electron transport chain.
What's the mechanism for the brainstem lesions, currents intermittence especially?
Myelination, I think.
Yeah, it's just, I'm not sure I have the exact answer, but it's,
Demyelinated.
yeah, it's demyelination.
Does the treatment for the, would a mock treatment do anything?
Why is it?
Good question.
It's an immunologic.
But it's mitochondrial dysfunction and to produce myelin.
So you
a
think
lot
that
of
the like
factor cells.
that wouldn't do anything because it
Yeah.
wouldn't be.
Luckily, in this patient, we're kind of just hanging out and doing it.
That's awesome.
A great case. Yes, somebody needs to light a fire under. Their
I guess one comment, this was awesome, thank you. For the ND4 variant, I think, Lumovoq exists, gene therapy exists, and it has pretty stellar results. But it costs a lot of money.
All right, any other questions for Harris or any of the other cases? All right, thank you all so much. It was a great. Orientation, but I think you guys should take a break before whatever comes next. Right.